gone deep down the surgical hematology road this week. So I want to go through DVT prophylaxis, full anticoagulation, and antiplatelet therapy, and the coagulation cascade, and how all of this ties together. So DVT prophylaxis, we're typically using low molecular weight heparin, which is Lovenox, or subcutaneous heparin. And the mechanism of action is that heparin basically increases by 1,000-fold, if you will, the activation or the way antithrombin 3 works, okay? So these are your mechanisms of action and the drugs. So a patient on full anticoagulation could be on an heparin infusion, but nowadays we like to use the novel oral anticoagulants or the 10A inhibitors such as Xarelto, Eliquis, or a patient could be on old school warfarin or Coumadin, which inhibits the vitamin K dependent factors, which are 2, 7, 9, 10, never gonna clot again is how I say it, because it is a vitamin K epoxide reductase inhibitor. All right, then antiplatelet, totally different. Aspirin and Plavix are the two I'll give. Plavix, the other name is clopidogrel. Aspirin is gonna be an irreversible cyclooxygenase inhibitor, whereas Plavix works on the ADP receptor on the actual platelet. So the intrinsic and extrinsic pathway merge at factor 10A, and that's where your 10A inhibitors come into play, your Eliquis and your Xarelto. Then we get all the way down here, there's also thrombin inhibitors, which prothrombin to thrombin is factor 2A to factor 2, and then fibrinogen to fibrin, and that's what's gonna allow platelets to actually stick together, okay? So this is truly a full package here of surgical hematology and a very quick rendition of your clotting cascade. So I think this will be very helpful. You always need to remember your mechanism of action of your drugs. It's gonna help you with your pharmacology, linking your physiology, linking your pathology, and it makes things not memorization, and it allows you to understand them. That is the key to knowledge in general.